if you want to introduce yourself, and then just minimize that, and you'll go to your thing right behind you.
Minimize what?
I'm sorry, right there, and it'll make this screen go down, and then you can
Okay.
have to.
I'm assuming everybody can hear me. This is Dr. Craig.
Hello, Dr. Craig.
Okay.
Yeah.
Yes, sir.
Okay, so this is Dr. Craig. Let me pull up my screen here so we can get started. I should be able, there it is, get the slideshow up. Okay, so what we're gonna, whoops. So we are going to do an initial attempt at trying to explain atrial fibrillation. The main purpose of having this talk was because we were talking about managing cardioem drips. When people come in with uncontrolled atrial fibrillation, sometimes we have no choice but to use intravenous management to get more rapid control than what we can achieve with starting on pills. So that's been an issue here for a long time because there's not been a lot of experience and there's a lot of confusion, and it usually requires putting people in the ICU. And when everybody understands how this is done and how we do it, really it shouldn't really require putting people in the ICU to manage cardioem drips. So the purpose of this talk today is mostly to educate people a little bit about atrial fibrillation. I think it's much easier to explain how to manage cardioem drips if people have a basic understanding of what the problems are with atrial fibrillation and what we're trying to accomplish with our interventions. Then it's easier to understand why we do what we do with drips. So the first part of this talk is really just a little review of what atrial fibrillation is. Once we do that, then we'll talk about the various ways to treat it, and then at the very end we'll kind of get into the do's and don'ts of how to manage cardioem drips. So I wouldn't expect this to be an end-all discussion, but if we at least get everybody kind of on the same page of what atrial fibrillation is about and what we want to accomplish, then we can work together on putting a plan together on how to manage these people a little bit more simply and adequately without having to put people in the ICU all the time. So if anybody has any questions as I go along here, I mean, I'm going to be asking a few questions. If anybody has any answers to these questions, just unmute yourself and let me know what you're thinking. So everybody should recognize that this is atrial fibrillation. So the first question is, does everybody know how to identify atrial fibrillation? Does anybody have any questions about how to do that?
Well, it's an irregular heartbeat.
It's irregular, so if you look at the distance between the R to R's, it's not the same beat to beat. Sinus rhythm is never exactly the same, but it's pretty close. So when you have, you know, a longer space between some R to R's and a shorter space between some R to R's, and it just bounces all over the place, that's one sign of atrial fibrillation. And there's a second sign. What is that?
No P waves before it.
Right. So does everybody know what a P wave is, right? So normally the line between the two heartbeats are the R waves here. So this is one heartbeat, this is the next heartbeat. Usually the line between those two on an EKG is flat, except for a little bump right before the R wave, that's the P wave. So that's the first thing, is making sure you know how to identify atrial fibrillation, because if you're monitoring a cardioem drip and the patient happens to go back to sinus rhythm, that's important information to pass on to the doc. Okay, so making sure you understand that. Now, there are a few things that can be confusing. So the top strip in this slide is atrial fibrillation. Okay, so as you can see, there's differences in the heart rate beat to beat. Some R to R's are wide, some are narrow, so it meets the criteria for that. And if you look really closely, there are no P waves right before the R wave. So this is the top row is atrial fibrillation. The middle one, this one here, this is not atrial fibrillation. sensitive touchscreen. The middle one's a similar rhythm, but it's called atrial flutter. So does anybody know why it's called atrial flutter? So when you have atrial fibrillation, there is no actual contraction of the atrium. It just flutters. I mean, it doesn't flutter, that's the wrong word. It just just kind of shimmies. It doesn't do anything. It just sits there and kind of quivers. Quivers is a good word. So it's not the same. The bottom row, you see P waves, but it's still irregular. So all three of these rhythms are irregular. The bottom one has P waves, so it's not atrial flutter or atrial fib, but sometimes people have P waves that just bounce all over the place. So you can have an irregular rhythm because there's multiple P waves trying to pace the ventricle. So you get different looking P waves and it causes an irregular rhythm, but there's one isolated P wave in front of each QRS. And that's called multifocal rhythm, multifocal atrial tachycardia if it's fast, but it's not atrial fibrillation, it's not atrial flutter because there is just one readily identifiable P wave for each QRS. Flutter is kind of in between. It looks like sawtooth, okay? So what you can think, oh, good grief. So what happens here is with atrial flutter, the atrium is trying to contract, but it's not doing it very effectively. And it's a twitching sort of thing, but it's very regular. And so these are almost like P waves, but they're not full P waves. They're just the atrium trying to contract, but not really contracting. And if you measure the difference between these flutter waves, it's always about one big square box. So one big square box is a rate of 300. So flutter waves, these little sawtooth waves in between the QRSs, those usually are at a rate of about 300. And then the subsequent ventricular rate is if it's 2 to 1, you got a heart rate of 150. If it's 3 to 1, you got a heart rate of 100. But it can be irregular. You can't see an identifiable P wave, so it gets confused with atrial fibrillation, but it's not the same thing. So, does anybody have any questions about that?
So I wanted to clarify on the AFib. You said there's no contraction of the atria because the P wave is the indication of the atrial contraction.
Yes.
So this big QRS is the ventricle.
Yeah, so that's what this next slide was trying to get to. So let's just back up and talk about the parts of the complex here. So the big spike that goes, it's a sharp spike up and a sharp spike down. It can look like anything. It can be all up, it can be all down, or it can be half up and half down, but it's a very sharp spike up and down. What is that?
The ventricle contraction?
So the ventricle is, right, it's depolarization. So it's it represents the ventricle actually contracting and pumping blood. The reason it shows up on the EKG is because when the heart does that, the electrical activity is going through the heart very rapidly. That's what makes the heart contract, and that's the depolarization. That's what causes the heart to contract. And on the EKG, it looks like this spike that happens very quickly because the heart contracts very quickly, but that is the ventricle squeezing blood out to the body, right? So what does the P wave represent? Anybody know? So on a normally the way the heart beats normally.
It's on the screen, guys, answer.
So the way the heart's designed very effectively. So when the heart beats, the next thing it does is relax, right? So as the heart relaxes, there is some blood that just starts going into the heart all by itself because the ventricle is empty, it's relaxing, blood starts going into the heart. But at the very last second, before the heart beats, the P wave happens. What does the P wave do? The P wave makes the atrium squeeze. All right. So the atrium just sits there. When the heart first starts relaxing after its heartbeat, the first thing that happens is nothing. The atrium's just sitting there waiting for the heart to fill all by itself as best it can. But right before the heart's going to squeeze to pump out blood, the P wave happens, and that represents the atrium squeezing the last amount of blood to go into the ventricle. Does that make sense? I got a slide here to talk about that more in a minute, but that's why you see on a sinus rhythm a P wave followed by a QRS, a P wave followed by a QRS, because it's the P wave's job to do two things. It's the P wave that stimulates the atrium to squeeze and finish filling the ventricle, and it's also the P wave that tells the heart to wait about 120 milliseconds, and then the ventricle squeezes. So the P wave does two things. It finishes filling the ventricle, and it tells the heart, go ahead and beat. And there's just that little delay. It's called the PR interval. So a PR interval is anywhere from about 100 to 200 milliseconds is normal. That delay is there so the heart has time to accept the blood that's being pushed in by the atrium contracting. Make sense? So the P wave tells the atrium to squeeze. That finishes filling up the ventricle with blood. Then there's a little slight delay while it gets filled, and then the heart squeezes and all that blood goes out to the body. But at that point, the ventricle has been filled up completely. It gets filled up partially by the blood just flowing in automatically. It finishes getting filled up by the atrium squeezing blood in there, so now it's full, and then you got a big strong contraction to pump the blood out to the body. This is what we see on an echo. It's a perfect example of what I was just talking about. So this is a cross section of a heart right here. This line represents an echo beam. We do this in the office all the time to look at how blood is flowing into the heart, right? So this is like a radar, traffic radar beam, all right? So this beam from the echo, good grief, this is pretty sensitive. This beam from the echo that I'm looking at right here is pointed right at the mitral valve. All right, this is the atrium, this is the ventricle. So when this mitral valve opens, blood goes across this valve into the ventricle. And this beam, this echo beam that's looking at that blood flow, shows us when the blood is flowing and which direction it's going. All right, so what you see is labeled E and A. Mm-hmm. So the E is when the blood first starts going into the ventricle all by itself with no push. Just when the heart's empty and the valve's open, there's blood that just starts going in there. And that's the first wave of flow you see. So that first little peak called E, that represents the first flow of blood into the ventricle with no help from the atrium. That's just the blood that goes in passively. Then there's eventually that passive flow starts to diminish because that's as much blood as the passive flow can get in there. And then what happens? The atrium contracts. And that causes what's labeled the A wave. So again, the Doppler that we're looking at here can detect the two phases of flow. It can detect the blood going in automatically, which is called the E flow. And then right before the heart's going to contract, the atrium squeezes in the last bit of blood. That's called the A flow. So this next slide sort of shows it a little bit better. So right at the top, you see an EKG, right? You see a P wave and you see a QRS, right? So look at the E wave. The E wave shows flow coming into the heart before the atrium ever contracts, all right? Good grief. So When the heart relaxes, blood starts flowing in right away. That's the E-flow. And that happens without the atrium doing anything. That's just blood automatically going in because the heart's relaxing. It's kind of sucking in blood as it relaxes. And then look what happens. That flow kind of stops flowing, right? Until you see the P wave, right? See the P wave up above?
Mhm.
So there's the P wave telling you that the atrium is contracting right there. What happens after the atrium contracts? You get the A flow. So it's the A flow that finishes filling up the ventricle. Without the A flow, you've only got a half full ventricle. If you've only got a half full ventricle when the heart contracts, how much blood goes out?
Half.
Turns out it's about 80%. Half would seem right, but it's really, these are pressure waves, they're not actually flow waves. So what happens is you fill the ventricle about 20% less when you have atrial fib because you don't have that atrial squeeze. People call it the atrial kick. So without the atrial kick, the heart has to just pump out whatever blood it gets in there automatically without the push from the atrium.
Without the P wave.
Without the P wave. So that's the bad part about atrial fibrillation in general, whether it's a normal heart rate or a fast heart rate. You lose the atrial push, the atrial kick. The ventricle doesn't get filled up with as much blood because you lose that atrium squeezing blood in there to get the final filling. Therefore, when the ventricle squeezes to pump blood out to the body, it's not pumping out as much blood as it would otherwise. Okay. When the heart rate is normal, that little bit of lost fill is not a big deal. Okay. But, oops, go back the other way. But here's what happens as heart rates get faster. We just talked about the fact that with atrial fibrillation, you use that atrial filling, that atrial kick. So you're dependent totally on how much blood can flow into the ventricle all by itself without the push from the atrium. And if you've got a normal or a slow heart rate, that means there's plenty of time between beats to get as much blood as you can into the heart, right? So the longer the heart has to fill without the atrial kick, the more blood it's going to get. What happens when the heart rate gets fast? Somebody comes in with atrial fib and
Doesn't get
RVR.
enough time to fill.
Yeah, the amount of time between contractions is so short that then you not only lose the atrial kick, you also lose the time it takes to fill the ventricle passively. So the higher the heart rate, the less time there is for the heart to fill, and pretty soon what happens? Blood pressure starts to drop because cardiac output goes down. So that's the main problem with rapid atrial fib, is that you lose that atrial filling, the heart rate gets too fast, and then it gets to be a vicious circle because blood pressure starts to go down, the body tells the heart to beat faster, and then it gets worse. And that's when people crash, right? So it's the lower cardiac output that drops the blood pressure. And the higher the heart rate goes, the lower the blood pressure goes. So here's what I see happens in a lot of ERs and a lot of nursing units. They got a patient with atrial fib, and all of a sudden the blood pressure starts dropping,
Mm-hmm.
and they're on metoprolol. And they think metoprolol is a blood pressure drug. So what do you do when blood pressure drops?
Stop it.
You hold the metoprolol, even pills, right? Even pills. So the common thing that happens is patient comes in with atrial fib, and all of a sudden their heart rate starts to go up, but all the nurse is really tuned into is the blood pressure. And the blood pressure goes down to 100, it goes down to 90. And so they don't give the metoprolol. What happens?
Their heart
Rate goes faster. And then what happens? Blood pressure goes lower.
Down.
So how do you fix the blood pressure? You give the metoprolol, right?
Oh,
Right?
okay.
So I get calls all the time. Do you really want to give this metoprolol? The blood pressure is only 90s. I say, what's the heart rate? 130. Absolutely.
Okay.
So
All right.
it's more for the heart rate.
It's totally for the heart rate.
Okay.
Yeah, it's totally for the heart rate. That's a very common, I wouldn't say misunderstanding, just lack of understanding. That people just have it tuned into their mind that metoprolol or cardizem is for blood pressure, but in patients with atrial fib and a high heart rate, it's there to keep the blood pressure up, because if you let the heart rate get too high, the blood pressure goes down. It's kind of paradoxical unless you really understand what's going on. So that's the essence of atrial fib and why we're concerned about rapid atrial fib. All right. So so if people have an otherwise completely normal heart, if their heart's completely normal, their valves are completely normal, they got a normal ejection fraction, their blood pressure is usually normal, those people can actually tolerate a pretty high atrial fib rate because they got lots of room to compensate. They got a lot of reserve to hold them through. So some people come into the ER, their heart rate's 140, 150, but their blood pressure is fine and they feel fine. That's understandable, because not everybody needs an IV drip, right? If people don't have one of these other problems, they may do just fine with rapid atrial fibrillation, and you've got 12 hours or 24 hours to give them pills. You don't need to put them on a cardizem drip, all right? So, and basically, so we're talking about valve disease. If they've got MR, mitral regurgitation, what happens then is the heart squeezes. Not all the blood goes out to the aorta, part of it goes back into the lungs. So they don't tolerate rapid atrial fib. Or if their EF is low, they're just barely pumping out enough blood already. They don't have any reserve to handle the faster heart rate, so they crash. This last one was supposed to say stiff LV. It came out still LV, but it's supposed to say stiff LV. So one of the common things is that people who have a long history of high blood pressure, their heart doesn't get weak. They don't have valve problems, but the heart's a muscle. Blood pressure's high. That makes the muscle get thicker. It's just like any other muscle, it bulks up. And it's called diastolic dysfunction. So diastole is when the heart's filling, right? Systole is when it's pumping. Diastole is when it's filling. So if you've got a normal heart that's not bulked up, it can relax very easily and accept that passive inflow. So a normal heart can handle passive inflow because it relaxes and lets that blood come in. People that have bad hypertension, their ventricle gets very stiff. It doesn't relax very well. So it can only expand so much to accept that extra passive inflow. And so when people go into rapid atrial fib with bad hypertension or a lot of diastolic dysfunction, they don't tolerate atrial fib because their heart can't relax to accept that passive inflow. So usually if somebody's crashing with rapid atrial fib, they've got one of these things going on as well. So not only do you have to treat the rapid atrial fib by getting it slowed down, you've kind of got to be aware of what the other issues are. And it's not your job, but the person taking care of the patient, the doc, the cardiologist, how he addresses the rest of the medications depends on these other factors. All right. So we've already kind of covered this. If you've got one of those factors and you have rapid atrial fibrillation, first thing it does is cause cardiac output to drop. Then it causes blood pressure to drop. Blood pressure drops, renal perfusion drops. Renal perfusion drops, people start retaining fluid retention. Their lungs get congested. They get more short of breath. If you don't, hopefully we intervene right at the beginning of this. But if you don't, they just keep going down the scale, right? Cardiac output drops, blood pressure drops, renal perfusion drops, they start retaining fluid, lungs fill up, they're in heart failure. If you don't fix it, then they get hypoxic and they're in shock. So our job is to kind of get them between steps 1 and 2 here. So again, this talk mostly was organized to talk about intravenous drips, but for obvious reasons, I mean, you deal with this on the floors too. And so if the patient comes in with an elevated heart rate and they're stable, it sort of depends what other factors they have going on as to how high that heart rate has to get before they start seeing problems. But when you see blood pressure going down or pulmonary congestion developing, then you've got to be more aggressive. But if you don't have those things, but the blood pressure is okay, If the saturations are okay and they're not short of breath, you don't have to put them on a cardiosim drip. You can start them on medications. All right. If their blood pressure is dropping, if they're getting short of breath, if they're getting hypoxic, if they got some sort of signs of ischemia on their EKG or troponins are up, then you've got to be more aggressive and start an IV drip because you just want to get this under control as quickly as you can. A corollary of that, this is kind of a pearl I try to teach my fellows when I was back in the days. Just about everybody who comes in with rapid atrial fibrillation is fluid overloaded, even if they're comfortable. So what happens when you're fluid overloaded?
A whole slew of stuff.
Yeah, so when your fluid is overloaded, it's like you got more fluid in the balloon. All right, where's the balloon? It's the atrium. What happens if you got more fluid in the atrium? It stretches. It stretches the atrium. What happens when the atrium stretches? It makes atrial fibrillation worse. So this is not for you guys to be responsible for, but I used to teach my fellows that if you really want to control atrial fibrillation, you don't just control the heart rate, you control what's triggering the heart rate. And sometimes it's usually, if they've been in it for a while, there's always a component of fluid retention because the atrial fibrillation makes them retain fluid. That causes the atrium to stretch. Then it's harder to control the atrial fibrillation. So just about everybody I see with rapid atrial fibrillation that's new or out of control, whether they sound wet, whether the chest x-ray shows anything or not, they just about all benefit from IV Lasix.
Okay.
All right. So if you have time to treat them orally, again, I think all those people benefit from probably some diuresis. Makes it easier to control because you decompress the atrium. The standards is metoprolol and cardizem, PO, right? I personally think that tartrate is better than succinate. It's shorter acting. You got to go twice a day, but it's also more rapid acting. So it takes longer to get people under control if you start on succinate rather than tartrate. And then tartrate you have to give every 12 hours, but you get a better result. And I even see a lot of the younger cardiologists that they're very scared to do this. They start with 12.5 or 25. It does nothing. I mean, there's exceptions, of course, but I just about never start less than 50 if you really want to do this. When it comes to cardizem, there's two kinds of cardizem. There's long acting, which is the 120, 180, 240, or there's short acting, which is the 30, 60, 90. It was established a long time ago in cardiology that you should never use short acting, but it happens all the time. It can be, in some people it's hazardous. So I just about always, if I'm going to use oral cardizem, I always use long acting CD, Exol, whatever you, diltiazem, you know.
Why is the short acting
Just experience.
counterproductive, I guess? It just is.
Just as is. It has a more, probably has a more negative effect on ventricular function than the long acting does. So you can actually trigger heart failure. People with hearts that aren't exactly strong, it's more like you can get yourself in trouble easier with short acting than you can with long acting. The other thing it's true for metoprolol, it's also true for cardizem. You've got to get about 5 doses into people before you really get steady state. So don't be surprised if the first dose doesn't do very much. The second dose may not. You usually got to get to 3 to 5 doses before you start to see a result. That's why you can do it for people who are stable, but not for people who are going to crash before that. If you are starting oral metoprolol or oral cardizem, you can push a few doses of intravenous DIG just to kind of speed things along. You got to be careful about digoxin for the long term because you can get DIG toxic. But even people with terrible kidneys, you can load them with up to 1 milligram and they won't get DIG toxic. So given incremental doses of 0.125 or 0.25 2 or 3 times is perfectly safe in people even with bad kidneys, as long as you don't go over about 1 milligram. And usually it takes about 30 minutes to see the effects. So if I give a dose, I may wait an hour or 2 hours to give a second dose. So let's talk about IV card. Now that's the background of atrial fib. All right. So suppose we are going to put somebody on a cardiosim drip. How do you titrate a cardiosim drip? I don't think you do.
There is no titration.
There is no titration. Why is that? When you're titrating dopamine, dobutamine, levofed, you've got blood pressure to titrate against. What happens when you're titrating atrial fib? Look at this strip. Is the heart rate 60 or is it 150? Yeah, the very nature of atrial fib is it's irregular. So how do you titrate something that's irregular? Okay, you look up at the monitor, it says 120, so you turn it up. You look up again, it says 60, you turn it down. You look up again, it says 100, you turn it up. You never win. You change cardiosim drips in increments. There's really no rationale for titrating it against the monitor heart rate, because what the heart rate monitor tells you could be all over the place. There's just no fixed number to titrate against. So what I like to do is just give the nurses a fixed order, say, keep it at 10. If the heart rate is consistently below 80, 60, then call me. Or I might, depends on the order. I may say if it gets down to 60, turn it down to 5. But I prefer adjusting the doses in predefined increments rather than titrating it. Because if you titrate it, you'll never catch up. Mm-hmm. So you give the dose it takes to get it under control, and you start adding PO meds, and when it starts to come down, then you just incrementally decrease it by 15, 10, 5, 2.5, or 0. All right? Mm-hmm. Or if it just drops abruptly, you can just turn it off. But we can talk about that more at a later date, exactly, the orders. But first, I think the most important thing is just to understand the concept here. So I actually prefer intravenous cardiosim rather than intravenous amiodarone. Now, a bit of that is personal preference and experience. A lot of the newer cardiologists go right to amiodarone. I don't like that for a couple of reasons. First of all, IV cardiosim usually acts faster because you give a bolus dose of about 10, you get the blood level up very quickly, you start a drip, and you get an immediate result. Sometimes with amiodarone, you know it's a fixed rate. It's a bolus dose, but then it's a fixed rate for 6 hours. Then the maintenance rate after that, and you're kind of stuck with that. You just got to wait to see what happens. With cardiosim, you can more, I think, if you understand what you're doing, you can manipulate the drip according to what you're seeing. You're not just stuck with a fixed dose of amiodarone. And you get to steady state effect with IV cardiosim much quicker than you do with IV amiodarone. Second thing is if the patient's on a rate of 5 or 10, and you need to go up to, if you're on 5, you need to go to 10. If you just turn that drip to 10, it takes about 2 hours to see the effect. Okay? If you want...
For amiodarone?
No, we'll go back to cardiosim,
okay,
sorry.
Cardiosim.
So if you're on a cardiosim drip and you're at 5 milligrams and the heart rate's still too high and you want to go to 10, the doc says go to 10. If you just turn the drip to 10, it takes about 2 hours to get to steady state at the new level. If you give a bolus dose right when you make the adjustment, you get the level up quickly, and then the higher rate keeps it there. Now, sometimes the patient will drop their blood pressure in those first 10 or 15 minutes. Usually it's not a big deal. But if you don't give that bolus dose when you turn up the drip from 5 to 10 or 10 to 15, it takes forever to get the effect. All right. We always say you don't, in my opinion, you don't titrate cardiosim, you do it in fixed increments. The other advantage is it's fairly short acting in the intravenous form. So unlike amiodarone, which if you turn it off, it takes a while to get out. If you're getting an overly response and heart rate really drops, you can turn it off and it's gone pretty quickly. And it's very easy to transition from IV cardiosim to PO cardiosim. when you transition from IV amnio to oral amnio, it takes a month because you have to load the body. That takes weeks. All right. So as I said, sometimes you may get a little drop in the blood pressure when you give that first bolus dose. It's usually pretty mild. It's usually pretty brief. I don't usually worry about that. If it, you know, we'll talk about that some more later, but usually it's not a problem. And again, you don't titrate based on a specific heart rate. You make incremental adjustments based on sort of average heart rate. And usually, you know, if you change the dose, you got to wait 30, 60 minutes to see if you're going to get what you want. So again, usually, unlike titration orders where the doc can say just titrate to keep the heart rate, keep the blood pressure map at 65, it's hard to do that with cardizem. So you can't say, it never made sense to me to say titrate for heart rate of 70 because then it's all over the place. All right. So how, you know, and how fast you are able to come off the cardizem depends on what other medications have been started. Usually something is started orally, so as it kicks in, then you can come down on the drip. It's okay to start oral cardizem while you're giving IV cardizem. Don't let the pharmacy tell you otherwise, because if you don't start the PO while you got the IV going, then you're starting over with the PO, right? But again, that's not your. That's got to be the doctor's orders, but I think it's some.
Pharmacy will call for clarification.
Yeah, so I think, you know, there's only so much you can absorb here at one time. We'll probably have another sit down when we can really talk about specifically how we're going to do this, what kind of order sets are we going to have, right? So if the patient's stable, improving, if the saturations are good, if the heart rate's decreasing, if the blood pressure is coming up or staying within range, then you know you're fine. The other thing about atrial fib is because it's erratic, automatic blood pressure cuffs are not always accurate. They can underestimate blood pressure quite a bit. So if you think you're getting a low blood pressure, double check it with a cuff and a stethoscope. And obviously, I mean, we'll get to this when we talk about orders another time, but you know, if you're getting the effect you want, you just keep going. If something's getting out of whack, if the heart rate's not improving, if the blood pressure is getting out of range, then you call the doc to get specific orders. Again, some people, you can make a case for IV amiodarone being a little bit safer in people with really low ejection fractions. That's probably the one situation where I might opt for that. The cardizem can make the heart failure worse, but that's a physician call and not your call. And again, IV digoxin can be effective just as the main way to treat this until you start pills, or it can just be a booster to get started. Usually you give it in increments of 0.125 or 0.25 milligrams every 30 to 60 minutes, and it's safe to go up to a full milligram without getting ditch toxic. So, again, this wasn't meant to be an exact discussion of order sets. I think that is better done once we have a basic understanding of what atrial fibrillation is and generally how we're trying to approach this. But we'll stop there unless anybody has any specific questions.
Does anyone have questions?
I think you explained it very well.
Yeah,
Thank you.
that was great.
I'm from OB and that, I understood that.
It's pretty straightforward if you know what you're doing, but it can be really confusing if you don't have the basic understanding of atrial fib.
I really like the way you described the blood pressure dropping without the, metoprolol and how.
It's a common issue. Yeah.
I think that'll ease a lot of the nurses, because sometimes even
Do
when
we
we
give
get
it?
that
Do we don't give it?
clarification
Yeah.
and they say give it, then they're still scared because they may not understand that this is what is causing that
Mm-hmm.
drop.
I used to question it several times when I was on the floor. So.
And I tell nurses, it's not just this hospital, it's every hospital. I never mind being called in the middle of the night if somebody has a question.
Mhm.
Do I give it or I don't? Do I don't give it?
Mhm.
If you have a question, call me. I mean, then it's on me, right, first of all. But second of all, most of the time, I'll tell you to get it.
Okay.
Really appreciate you taking time.
All right,
Craig.
good.
Thank you, Dr. Craig.
All right, we'll get
I'm
back
glad this
together.
one
Thank
didn't
you
get
so
interrupted
much.
like the last one.
I know.
That would have been a 2-hour
That was
session, right?
Okay.
All right, thank you all.
We didn't
Thank
get a repeat
you.
of
Thank
that.
you.
That makes sense.
Yeah, these folks did our bingo session.
Oh my gosh.
Hey, Nicole, it's Karen.
I don't know anything about cardiac.
Are you gonna stop this recording?
Of course, like just
Yeah,
right through, but he did explain it very
Like all rhythms, I think he needs to.
yeah, I hate rhythms.
Me too.
Did you stop recording?
No, that's what I'm looking at right now.
I think you should stop recording, but then start again and record the meeting.
This is then just for med search.
Oh, so we're done?
Hello?